In terms of an intrarenal acute kidney injury, there are three main sites where the insult can occur. There is the glomerulus, where you can get a number of different diseases known as the glomerular nephropathies or glomerulonephritis. There is the tubules, where you can get tubular damage and tubular necrosis, known as ATN, which we've already discussed. And there is the surrounding interstitium around the tubules, which can be a focus of inflammation, known as acute interstitial nephritis or AIN. For these pathologies, ATN is usually the result of prolonged or severe renal hypoperfusion, and so essentially shares all the same etiologies as discussed for pre-renal acute kidney injury. For acute interstitial nephritis, or perhaps more accurately, acute tubular interstitial nephritis or ATIN, the underlying etiologies include things like viral infections, bacterial infections, autoimmune diseases, and perhaps most commonly, drug-induced causes, including the three main drug classes of antibiotics, non-steroidal anti-inflammatory drugs, and proton pump inhibitors. Specifically, the penicillins, cephalosporins, sulfonamides, and fluoroquinolone are the most commonly implicated antibiotics, and drug-induced AIN should always be suspected if there's a temporal relationship between starting a medication and the development of AIN. The AIN can occur as shortly as 1 to 2 days after starting the medication, but the time to onset can also be as long as a few months in the setting of NSAIDs in particular, as well as the proton pump inhibitors. The typical picture for an AIN is when a patient presents with an intra-renal AKI, but also has features including things like a fever, possibly eosinophilia, and a diffuse maculopapular rash. Because it is an inflammatory process, patients often need to have steroid therapy if treatment of the underlying cause, whether it be the autoimmune disease, the infection, or withdrawal of the offending drug, is inadequate on its own. The glomerulonephropathies, or GN, are a diverse group of renal disorders which have two typical presentations, known as the nephrotic syndrome or the nephritic syndrome. Briefly, the nephrotic syndrome is characterized by a high degree of proteinuria, more than 3.5 grams per 24 hours, hypoalbuminemia, usually less than 25 grams per liter, and edema, which can be in atypical locations such as the hands and the face, as opposed to a lower limb predominance in the setting of heart failure. The underlying pathology is usually a structural problem with the glomerular basement membrane, which normally prevents the leakage of large amounts of protein and albumin into the urine. Therefore, when there's structural pathology of the glomerular basement membrane, you can get significant amounts of protein leaking through into the urine. And as a consequence, the serum albumin will be reduced, which leads to a reduced oncotic pressure and therefore edema. A compensatory mechanism to try and maintain the oncotic pressure is when the liver is able to increase its production of cholesterol and coagulation factors, which therefore leads to dyslipidemia and hypercoagulability. This clinical picture is in contrast to the nephritic syndrome, which is characterized by hematuria, which may also be associated with proteinuria. As opposed to a structural defect in the glomerular basement membrane, the nephritic syndrome is characterized by an inflammatory response in the glomerular basement membrane, which can lead to local destruction and therefore the leakage of red blood cells leading to hematuria. The inflammation at the glomerular basement membrane can significantly impact on glomerular filtration, which therefore leads to hypertension as another classic feature. There is a wide range of glomerular nephropathies with features of nephrotic syndrome on one end and features of nephritic syndrome on the other, and with many specific diseases having overlapping features of both nephritic and nephrotic syndrome. Some examples of nephrotic syndrome include things like minimal change disease, focal segmental glomerulosclerosis of FSGS, and diabetic nephropathy. Some examples of nephritic syndrome include things like ANCA-associated vasculitis, which causes a pauci-immune glomerulonephritis, antiglomerular basement membrane or anti-GBM disease, and post-infectious glomerulonephritis. Diseases with overlapping features of both nephritic and nephrotic syndrome include things like membranous nephropathy, membranoproliferative glomerulonephritis, IgA nephropathy, and lupus nephritis. In terms of investigations for an intra-renal AKI, an important thing to do is to look at the urine protein creatinine ratio, and if this is markedly elevated, it would suggest significant proteinuria, which would be in keeping with a nephrotic syndrome and possibly also a nephritic syndrome. If the urine protein to creatinine ratio is reported in milligrams per millimoles, you can multiply this by 10 to get the estimated protein excretion in milligrams per 24 hours. This is a reasonable alternative to collecting a 24-hour urine to measure the total protein, which can be tricky and sometimes impractical to collect. Urine microscopy is also important because you can look for dysmorphic red cells or a large amount of red cells, which would indicate hematuria and possibly nephritic syndrome. Microscopy can also detect casts such as red blood cell casts, which would be in keeping with nephritic syndrome, or granular casts, which would be in keeping with ATN. Microscopy may also detect things like fat oval bodies, which would be in keeping with nephrotic syndrome, or things like eosinophils or eosinophil casts, which may be seen in AIN. And of course, the treatment will depend on the underlying cause, which may also involve steroids for AIN or immunosuppressive therapy for the various glomerulonephropathies.